So what is arteriovenous malformation? Arteriovenous malformation is a complex neurovascular disease. It has basically three components, one arterial component and one nidus and one vein. Now it can present in various forms with multiple arteries and multiple veins, or single artery, single vein, single artery, multiple vein. All those permutations and combinations are possible. Now the problem is most of the arteriovenous malformations are undetected. They are only detected when the patient presents to us with a brain hemorrhage or seizures or intractable headache. Now what are the treatment available for arteriovenous malformation? The treatment for arteriovenous malformations are varieties of things. Like first of all, when an arteriovenous malformation is not really troubling a patient, we don't want to treat it. The second thing is that whenever there is a mild symptoms like some headache or seizure which can be managed with medication, then medications are good enough. And then when a patient has bled and come to us, definitely we recommend a treatment. The treatment can be a surgical excision of the AVM or an embolization or a radiosurgery. These are the three basic modalities of treatment for brain arteriovenous malformation. Coming to embolization, which is it's a very good treatment to offer for patients with brain arteriovenous malformation. This offers us treating the AVM without opening the skull. We go inside the femoral artery and get inside the brain into the arteriovenous malformation, the nidus, and we inject liquid embolic agents to get rid of this AVM nidus from the intracranial circulation. Now there are two types of embolization that we do predominantly. One is arteriovenous malformation for complete cure, and arteriovenous malformation embolization with a partially targeted embolization for treating the most dangerous angioarchitecture inside the AVM, like an internidal aneurysm which has bled, need to be tackled fast. And today we have a patient who is very young, 21 years old male, and he presented to us with brain hemorrhage on the left frontal region, and this blood has seeped into the ventricle with a ventricular extension. This patient we are going to do a partially targeted embolization. Why we want to do a partially targeted embolization? Because the AVM is large and patient has bled and he is in an acute phase, and there is internidal aneurysm which has bled, and we know why it has bled. And once we get rid of this internidal aneurysm and part of the nidus, then this is a fantastic treatment. Let the patient come out well, and in next 3 to 6 month time we can do a check angio if required. We can completely cure this AVM in the second sitting. It is good to be safe than aggressive and try to embolize or get rid of it completely and then landing up in a complication. Most often we see that people are so aggressive trying to get rid of this AVM in the first sitting and they land into complication. So this mostly happens if you have gone into the AVM, you have sucked the vein, the exit route of the AVM, but you have left some of the nidus and you cannot embolize. And this nidus which is left without a draining vein, without an exit path, they are going to bleed and patient can die of these problems. So better to do a partially targeted embolization in a patient who has those dangerous angioarchitecture as a large AVM. But if it is a small AVM, as a 7th grade 2 or 3, and you can get rid of it at one go, is fantastic. We must do that. So we should be very, very clear where we want to completely cure an AVM and where we want to do a partially targeted embolization. So this is a patient today who has a large grade AVM, who has bled recently, have an internidal aneurysm. Definitely a partially targeted embolization is a good way to go ahead and treat this patient. Whenever we want to treat a brain AVM, we must look at the angioarchitectures very, very carefully. And when we are looking at the angioarchitecture, the most important things that we have to notice is the arterial feeders, one or many, and the venous drainage, one or many, and what is the course of the vein. Then we have to look into the aneurysm that might be present in the feeding artery or in the internodal course of the AVM. So now look at this. This is a large aneurysm which has actually bled. That's why the patient is having a huge hematoma. So you can see this is an internodal aneurysm. This is coming out of the nidus, although it looks like as if it is going from the feeding artery. It's not the case. It is actually opacifying through the nidus. And when it is an acute setting, we are talking about a partially targeted embolization. So you must occlude this aneurysm and with part of the nidus so that the patient is safe and he comes out of this acute setting. Then we think of cure. And the second thing that we notice is that our feeding artery, and the feeding artery is basically, this is the one, and which is going to the nidus, the major one, and this is another minor one. So ideally speaking, we should go through the smaller branch and embolize as much as possible, and then we should go into the major branch and embolize as much as possible in a normal unruptured AVM. But here I am targeting to go into the large vein first, the large artery first, because of this internodal aneurysm which is proximal to this course of the artery, so I can get rid of it. If I try to go from here, I may not be able to reach here very soon. Second thing why I will choose this artery is because look at this vein which is just coming out of here, which is very, very close to this arterial feeder. So once I inject, it might happen that my onyx might just go into the vein and it might occlude the vein without getting much of the nidus beyond this. So I will try to go in here and occlude the aneurysm and as much as of the nidus, and then I will see that if I have a good penetration over here, that's fantastic. Otherwise we must stop and stage it for the second setting where we can occlude the nidus, the vein and the part of the artery. That will give us a complete cure in a controlled fashion with minimal complication. As for the plan, we are going into the major feeder over here which is close to the aneurysm. This is the aneurysm over here, and this is what is my target. So I'm just trying to go in here, and once we can do that, then we can start injecting the liquid embolics. So this is the internodal position, and this is a microcatheter run which is showing that this is the nidus and the vein also can be seen, the nidus and the vein, and this is a beautiful position for us. So this is my microcatheter position, and this is bang inside the AVM nidus. It's a good position to start. And now look at the opacification of the aneurysm, which has become very, very slow. There is a drop of onyx going over here, and you can see that aneurysm has become very, very slow and is only partly filling. So this is a good thing, and we should further inject, and we should get rid of this aneurysm over here. Here we can just look at it. It's almost been taken care of, but we'll still push and we'll get rid of this aneurysm, which is the cause of the bleed for this patient. This is the further occlusion of the aneurysm. Now we can see the onyx cast inside the aneurysm. This is fantastic. Now for example, we just continue to inject here, and we just try to opacify the vein and occlude the vein. Then patient will have a complication because there is a small arterial feeder going over and there is a small nidus, and if you continue to inject here, the vein will get occluded and this part of the nidus cannot be penetrated through here. So hence it is prudent that we stop here, and when the acute setting is gone, we just come here and put a microcatheter over here and get this nidus as well as the vein that is going. So this is the vein, this is the nidus. Now it is a small 1.5 centimeter AVM which can be easily tackled when the patient is stable and the hematoma is gone. He's having a large hematoma as we have seen in the CT scan. So let it settle down, and down the line in about 6 to 9 months we bring him for a check angio, and if required we just embolize this vein, nidus and part of the arterial system. Now there is no opacification of this aneurysm, which is occluded with onyx here. And now we will take the nidus as much as possible, and then leaving the vein and a part of the nidus, we can just come out, not to be very aggressive in an acute setting, and embolize as much as possible, around 60, 70, 80%, and then we just take it in the second sitting for the cure. Patient is okay?
Sir, take it.